discuss about diabetic, tractional and combined retinal detachment.
It's always a good debate. Thank you. Good afternoon, everyone. Dr. Thank you, Hemant, for asking me to be part of this instruction or this course. I'm going to talk to you about how I tackle diabetic TRDs and combined RDs. So uh, these are some things that we keep doing on almost on a daily basis, like diabetic retinopathy and its complications from the bread and butter of the ophthalmologists and retina surgeons. So pre-op evaluation is very important whenever you are planning surgery because these are complex cases. Systemic factors have to be optimally controlled. Examination of the anterior segment important for pupillary dilatation, lens status, lens clarity, and intraocular pressure. So if there is any lens opacity, it's better to plan a combined surgery with phaco-vitrectomy in these eyes. Otherwise, the view can get compromised for your complex surgery during the surgery. Always discuss the outcome with the patient and give realistic expectations. This is very important to avoid later on an unhappy patient because the outcome was not what he expected. And always have a surgical plan and review the OCT and the B scan beforehand so that you can plan your surgery about the need for bimanual dissection, need for the other procedures like PFCL, etc. Whether to use pre-op Avastin, I do not use it routinely at all. Only when there is an extremely vascular membrane that I have to operate, I use pre-op Avastin, which is usually given 3 to 5 days before the injection, and make sure that the patient is fit for surgery before you even inject Avastin. Because once you inject Avastin, the membranes contract, and you can see how the whole thing contracts and increase in traction happens. And if you are not able to operate within 5 to 7 days, then later on it can have a deleterious effect on the retina. So the timing of the injection is very important. The techniques, the basic principles are core vitrectomy with relief of anteroposterior traction, dissection of membranes causing macular and disc traction, staining and removal of epiretinal membrane and ILM in selected cases, endolaser and PRP around any breaks. This you could do either after fluid exchange or with PFCL depending on the situation, and then tamponade as needed. If there are no retinal breaks in a TRD, I do not use any tamponade. I just leave the eye with air and either use gas or silicone oil depending on the complexity of the detachment and the number of retinal breaks. We choose either gas or oil, and my first preference is always used to use gas. Some important tips are finding the plane for membrane dissection is very important. I'll show you a video regarding this, because once you find the membrane, that real plane, the membrane dissects off from the retina, peels off from the retina very easily, and you just have to sever the minor connections. And whenever the retina is mobile, I switch over to the bimanual technique. I will show you video. Homeostasis on the table should be very diligent and do not allow large quantities of blood to clot on the retina, because this can get stuck to the retina very badly, and trying to pull it off, you can cause more damage to retina. And that can be really a bane during surgery. So do hemostasis as it happens, do not allow clots to collect on the retina. Do not do, as a rule, I don't do a drainage retinotomy in a pure TRD. It's not necessary. If you relieve all the traction and leave the eye, the retina settles down without need for any SRF drainage. But if there are any breaks that happen during surgery or in a combined retinal detachment, it is better to drain the SRF. So this is just to show you the finding the plane. This is a patient with TRD. You can see there is a large fibrovascular proliferation there at the posterior pole. So once you have done the core vitrectomy, I'm just trying to find the plane here. Initially, it looks as if the plane is somewhere there, Actually, the plane is not there. There is one more glistening membrane there that you can see. So you need to actually pick up that membrane and go beneath that membrane. So once you do that, that is the right plane. This is not the plane. What I am trying is not the plane. I'm just showing you. This appears to be the plane of dissection, but this is not the plane of dissection. You need to go, there is another glistening layer there. Once you pick it up and then lift it, then you can see that the retina separates much more easily over a wide area. Now I have found the plane, and you can see there is a thin diaphanous membrane there. So once you find that, you see how the retina separates easily from the membrane separates easily from the retina, and you can see that only few connections remain, which can be easily cut with your cutter or with scissors if you are doing bimanual surgery. See, so finding that plane is one of the most critical and important steps in your membrane surgery. So second is we always use the cutter now. Earlier we used to use the delamination and segmentation with scissors, vertical scissors once upon a time. But today the cutter technology has improved so much. The cutter size has come down, the port has moved closer, and we are able to remove these membranes, do the segmentation, and even removal of the membranes like what I am doing here with the cutter alone. So we have cutters which have 10,000 cuts today available to us with a tapered tip, and even 27 gauge cutters I believe are very good. I don't have really much experience in using 27 gauge for diabetic vitrectomy, but I know some people really swear by it. So the cutter itself can definitely do lot of scissors work that we used to do because of its advanced technology, and we can in most of the times we are able to remove the membranes using the cutter itself, as I am doing here. And once we have removed all the membranes using the cutter itself, and then we achieve hemostasis, and this is what I was telling you, you can cause a break by pulling on the clot. So this is something that you should avoid. Having said that, I did create a break because of this maneuver. And in almost all cases of TRD involving the macula, and also in combined RD, I try and peel the ILM, because with this some ERM also will be there in many of these cases, and once you remove the ILM, you make sure that you are removing the ERM also, and peeling of ILM that is something I do in all these cases after staining with brilliant blue. So after this you can inject PFCL, or generally I am able to flatten the retina with fluid air exchange and do laser like what we did here. This was under air, we were able to laser the retina and laser all the breaks. So coming to another case of a combined retinal detachment. These are a little bit more difficult to handle than pure TRDs because the retina is mobile, and initial stage itself I got another break in this retina, trying to peel the, from the outside in technique I was trying to use here, and I created a break there, you can see. And then I was able to remove some of these membranes, and the retina, as it became more and more mobile, you can see that the SRF is being drained through that retinotomy. And I switched over to bimanual surgery because the retina was mobile here, and I could not really do the membrane surgery with cutter alone. And I do not shy away from bimanual surgery because I feel still it's a very elegant and most atraumatic way to remove these membranes, especially when there are extensive membranes with broad adhesions like this. And it's extremely helpful for hemostasis, because normally what happens, by the time you change the instrument and bring the diathermy, the bleeder would have the blood clot would have become more diffuse, and you're unable to identify from where it is bleeding. And I find that bimanual surgery using the suction and the diathermy tip allows me to coagulate the bleeder very, very efficiently, without damaging more of the retina. So bimanual surgery is what I prefer in tough situations whenever there is a mobile retina, and that's what we are continuing here. So with that, we continue bimanual dissection, and hemostasis is achieved. And finally, this is the last part of the membrane. You can see how the diathermy is being done with a very fine focus. And finally, when we have the final part of the membrane that is comes off from the retina, that's the final bit. You feel like waving it as if an Everest climber waves the flag. That's what you feel like once the final part of the membrane comes, and that's when you feel, yes, I have done a good job. So in conclusion, MIVS approach and advances in cutter technology have definitely augmented our surgeries and made it faster. We need not use scissors in all the cases, and Important thing again I would like to stress here, especially for beginners, is finding the plane. So this really is a critical step in membrane surgery, and once you find the right plane, your surgery becomes a lot more easier. And I would like to stress again, hemostasis is very essential during surgery because clots are the real bane of the retinal surgeon during surgery for diabetic retinopathy. And do not shy away from using bimanual approach, because I've heard speakers tell I don't do any more bimanual surgery because of the cutter technology is so advanced. I don't like to make statements like that. I do fall back on bimanual surgery whenever the going gets tough. Thank you very much.
Thank, thank you, Murali. I think it was very nice with all the videos you could explain the importance of the secondary membrane and the cleavage plane. Now we have Dr. Pramod Bhende talking to us how to douse the fire, that is how to do vitrectomy and the vitrectomy in patients with retinitis, endophthalmitis and such inflammatory conditions, which is always a challenge. Dr. Pramod Bhende is the head of Vitreoretina department in Shankar Netralaya, Chennai.
Thank you very much, Dr. Hemant, for including me in this instruction course.